Good afternoon. This is the Forum for Care Partners with research and experts. This is your opportunity to ask questions of our panel. I'm Jill Shapira. I'm facilitating this panel. I'm a retired nurse practitioner from UCLA, working with Dr. Mario Mendez in the Behavioral Neurology Clinic, and I started a specialized nurse practitioner-run behavior management program for care partners and persons with the illness. Dr. Wu is a professor of neurology at the University of California at Irvine. He takes care of patients with FTD and other forms of dementia, and he does clinical drug trials. Mary Ostrom is a professor of clinical psychology at Indiana School of Medicine. Her current research projects focus on how care partners of people with FTD choose whether to participate in research studies and how caregivers approach end-of-life decision-making. And Maura Silverman is a certified speech and language pathologist. She is the executive director of the Triangle Aphasia Project. She serves on national and international aphasia committees and publishes and speaks on aphasia, language problems, and how to get the community engaged in this issue. So for this session, it's about your questions. So I believe you were all given a card to ask questions, and then someone will come by, just, I guess, wave your hand, and we will try to answer your questions. So while we're waiting, I'll start with a question. And I'm going to address this to Dr. Ostrom. Our family has a tough time seeing eye to eye on what Dad needs and how best to support our mom, who is the primary caregiver. We think it's time to consider long-term care, but she fights us. How do we get on the same page?
Well, there's a million-dollar question. Is this on? No. Is it on now? All right. You can hear me now. Well, I find that is like the million-dollar question. When there's more than one caregiver, there's a family, there's, the spouse and adult children, I think it's very common to have different opinions based on our lifetime relationship with the patient, based on proximity. I always talk about, I'm in Indiana, so I always talk about the expert caregiver from California that flies in once or twice a year and has so much advice for mom and, his or her two sisters that live in Indiana. So I understand where all that comes from. I do get it. And unless we have a lot of time and money for big family therapy, which we don't, I really like to have the whole family in the room at the same time and say things like, today I want to focus on, Dad's care plan, and then we go around and say, what mom's wishes are, what the adult children's wishes are, and we try to get at everybody's concern and have a plan that focuses on Dad's needs. And unless we have guardianship for mom too, I really defer to her. I really do, as the primary caregiver, and then I want to hear all the adult children, and then I'll answer all the questions or whatever advice is. But until mom is really ready to make that decision, and again, unless we have guardianship over her decision making, she's an independent, capable adult, and we're going to go with her decision as long as these are younger families. We have the same discussion in Alzheimer's disease and later stage disease. Sometimes we worry about the cognitive capacity of the caregiver too, when I'm looking at 85 and 82-year-olds. But if I'm looking at 57 and 55-year-olds, I'm going to listen to the primary caregiver and then work with all the adult children to reach consensus and support of the mom, unless we really feel that somebody's in jeopardy there. If they can tell me that mom is making bad decisions And not only are we worried about her health and safety, she's putting Dad's life at risk, and he's unsafe, then that's another discussion. But in general, if the primary caregiver is doing well and she's not ready to look at placement in long-term care, I'm going to help her come to that, but it may take 2 or 3 meetings, and we can't just say your kids are right. So thank you for that.
I don't know. I'm going to add one little piece to that, because I'm not just a doctor. I play one on TV. No, I'm not just a speech therapist, but I'm also a caregiver for my mom, who's had a stroke and has aphasia. The great cosmic irony there. But on the way out from North Carolina, I watched a movie called What They Had. Has anyone seen that? It was fascinating because it was an adult, the adult children versus the husband, and where each of their perspective was in regards to caring for their mother who had dementia and making decisions. And each of their perspective is influenced by the lens that they're seeing it from, whether they're seeing it from a perspective of guilt or a perspective of what they need, or how they organize their life versus how their sibling does or does not organize their life. And I thought, I thought it was a really good movie because I thought it was very raw and it was honest. And as a middle child, oldest girl taking care of my mother, I have the brother in Atlanta and the sister in Rhode Island who, pipe in with nice job, good job. But then when something goes wrong, you do feel a lot of guilt. Yeah. So I really appreciate your perspective on that, and to understand that when we help families with decisions, that we have to understand each of their lenses and what perspective they're coming from.
And just one more I'd like to add, because it's the nature of the relationship, and in today's world and the length of the relationship. I have many reconstituted families, so all this changes when it's the patient's kids versus the caregiver's kids, because this may be a 35-year-old marriage. The couple are divorced young, they raise the kids. It's a little different. I have one family member right now that it's a late life remarriage. They met online, totally different. So they met online, all the novelty and excitement of a new relationship. I think he disclosed he was diagnosed with FTD, but she said he's the love of my life and married him, moved him from New Jersey locally to Indiana, and now the complications between his kids in New Jersey, her kids trying to support her here, that's a whole different ball game. So when they're a brand new marriage, it's crazy. So we have to look at all of those.
So let me add another question, because it'll piggyback on this. Another question we got was, if adult children live far away from the person with the illness and the primary caregiver, what are the top 3 things that the adult children can do to be helpful?
That's a great one.
That's a really good question.
That's a great one. I mean, when you're not there, and there is that guilt of not being there, and they try. So what I've learned from my caregivers, who are my best teachers, is they do appreciate the regular phone call and checking in. It's also nice now if everybody's texting, I see them saying, is this a good time for you, Mom? Can we talk? And it's easy to say, not yet, I'll call you back in 10, which is nice. So you're not, if you're in the middle of a bath, you're not rushing for the phone. So that kind of just sensitivity to the challenges. And then really, it's costly, it's time consuming, but there's still something about going and being with Mom and Dad. So trying to schedule, if there's 2 or 3 of you, just like your situation, making sure you schedule those visits regularly, but at a time where they could give Mara a break, right? Like for your brother to come up from Atlanta because you're here and he's there. So working together that way and providing support is wonderful. And then sometimes all we can do, and we can't get there, is maybe now with Uber Eats and the food delivery service, if Mom's had a bad day, to send pizza to send a favorite meal. Those are really instrumental things. The Googling, somebody can find a lawn care provider this year. When mom says, you know, the kid down the street has gone to college and isn't mowing the lawn, somebody can set that up from afar. Somebody can help get the elder law appointments. Somebody can make sure all the checks are being direct deposited and the bills are being direct paid from the account, and make the primary caregiver's life a little easier.
And I think as a primary caregiver, or even an adult child that's home to assist, is you have to ask for help. And it is so hard to do because you don't know what you need. I mean, you can say, I need something, I'm just not sure what it is, but sometimes it's a meal. Sometimes it's the use of their time or talent. My brother's an attorney, but guess who was the one who was looking to see if my father, when he passed away, I was checking to see if he had VA benefits. Dude, this is your wheelhouse, not my wheelhouse. So I think identifying and saying, you know what, your strength is in this. Would you do this for me? And follow through. It, you know, kind of divvying up the responsibilities to what somebody, you know, my sister may be really good at writing letters. Okay, can you write a letter about this? I think the hardest part about being the top three that you were saying is when there's radio silence. It's the worst. When I might bring up a situation that's going on with my mom, or I work with 200 different people who have aphasia, and a lot of times they'll say, I reach out to his kids and I share all the information of what's going on, and I don't hear squat back. And that is very frustrating. If I were in the other position, I would write and say, thank you for keeping me informed. Just the, you know, acknowledgement that radio silence is awful.
Thank you. The next, we have a few questions regarding physical violence and aggression. What do caregivers do when faced with physical violence from their loved ones? And in some cases, this has resulted in flunking out of memory care facility, being asked to leave. So I think this could, and specifically if someone has a language impairment too, so maybe this question could be addressed by all three members of our family. So perhaps we could talk about the language, the physical violence and aphasia, and how that might be dealt with, and then in general about safety issues. And then Dr. Wu, if you could kind of talk about how you think about medications when all forms of non-pharmacological modifications have been tried and they have been unsuccessful and it's an unsafe condition. Language
I'll make mine brief because behavior is not my wheelhouse as much since I deal primarily with PPA. But when you can't communicate, it gets frustrating, and oftentimes you will have outbursts even with just having PPA and no behavioral component. One of the things that I feel really strongly about is giving words, giving language to what is happening. A lot of times the act is very frontal, is very kind of automatic, and you need to provide words to it and provide those words in a multimodal way. So say them verbally, but also putting them down in writing, that this is what happened. I think it brings it awareness and understanding that a lot of times behaviors come out of an inability to express needs and wants. And as I joked in my session on communication tools and techniques, is that it's not always about their bowels. You know, if someone's trying to communicate with you, it doesn't mean they got to go to the bathroom. They might be afraid of something. They might be, you know, worried about something. Find out what it is by identifying what the behavior is and then backing up from there.
I agree with that. I tend to say to my groups, all behavior has a purpose. They're doing this for a reason, and our job as the caregivers is to be the detectives to figure it out. I always look to the family caregiver first, because I believe no one knows that person, that patient now, as well as their family does. So we really want to identify what is setting them off, and of course the language in our culture. Once you lose your ability to talk coherently, we then seem to think, you know, it's all downhill from there. And we tend to also look at all behavior as really part of like psychiatric illness, when it's really because they can't communicate, and it is frustrating. It would be like we take you and drop you in the middle of Greece or Turkey and you can't speak the language. You'd be so lost and so frustrated. So I get that. But how do we intervene in a person-centered way and keep the patient safe and calm, and the other person, the staff person, because you mentioned they flunk out of memory care. That's a big problem. I've had several families struggling with. We'll get crisis calls. I got this call and they want me to move dad. They're kicking him out, and it is so hard to find a place to place him, because once the new facility reads those notes, and there is like aggression or these behavior problems and agitation, and we've tried everything, there are very few places that'll take them on. And I have some gut-wrenching stories. And so then we look to, I know you're a neurologist, Dr. Wu, but our geriatric psychiatrists, I've been pulling them in even though they don't practice at those memory care units. We're trying to give voice to the caregiver to talk about person-centered care. I don't think the staff of those facilities have enough training
That's
to
exactly what I was just going to say.
There isn't enough training to address these issues and know what to do. And then I think it takes so long to titrate new psychoactive drugs and to play with those doses. So it's got to be a combination of all of these things, and the state boards of health and the accrediting bodies need to back off on this no chemical management. They got to back way off. If the facility can document, we've tried all the non-farm, we've failed at these interventions, we've worked with the family, it's person-centered, now they do need 3 to 6 months to get them on some meds to manage this. And then most important, after those 3, 4, and 5 months, to actually start decreasing and getting them off of Haldol. Because many times the behaviors will end and will change just as the disease progresses.
And I think, if I just add about the training, I think it's insufficient for you to tell somebody or a facility you're going in, my spouse has communication challenges. That's insufficient. They don't know what that means. To have a speech therapist that contracts with that facility, or a speech pathologist that's involved in an aphasia center in your area, go in and do a training. The training is so key, and then provide the tools, because maybe you won't get to the point where he gets kicked out if they know how to communicate with him.
Before Dr. Wu, I'm going to add something representing the AFTD. I know many people in the audience, at least in this morning, were new to these meetings and perhaps the AFTD. AFTD has developed a series of packets of information. Are some of you aware of these that you can give to healthcare providers? And we give them to facilities like nursing homes, like what is FTD and what are the things that are helpful. And we have written right now 25 different suggestions for different behaviors that many facilities are now using to help them deal with that. The other thing that I found at UCLA when we had a person who was booted out of a facility for aggressive behavior, we often had to admit them to a psychiatric hospital to get the behavior under control, and then it kind of reset the clock. They weren't labeled any longer as having that behavior problem, and then it reset it according to at least California state regulations. So that's another way of thinking about it. I believe you should also continue a relationship with the physician or the team that made the diagnosis that's expert in behavior. Even if you're in a facility, in case these problems occur, you have a backup. You have someone to go to who really understands the condition. Dr. Wu?
It's difficult question to answer, but usually when I have patients call me, family members call me, or a facility call me, it's actually have to decide whether a patient in the house by taken care by the family members or in the facility. It's very different situations. At home, Usually, the patient act out based on self-defense. The so-called violence usually is triggered by some stimulators or the stress. So the patient actually, violence actually was more self-defense, depends on the need, whether they actually did mad. For example, they want a glass of milk, but the wife did not understand and give a glass of water, so that's what make them act out, the communication, misunderstanding. So that's kind of more easy to resolve if caregivers actually more carefully to able to understand what the situation was. Then you don't have to use medication. So every situation you have to understand in a more, put into a context. But in a facility, it's very different. It really depends on which facility and which state. Every state have different. Right now, the facility actually national-wise have corporation run the facilities, or the facility is so-called the board and care, which is more new, just 4 or 5 people run by an owner, and in 9 times only one person. They have to watch out for 4 people, and they really cannot tolerate one person acting out, yelling, shouting, or kicking, or want to get out of the place. So in that case, that's usually when they request, I want the PO to stop this behavior, otherwise the patient will not be there. So they will have no time or bring someone to say, let's make a watch, because in the board and care facility, there's one person at night watching for 5 people. So there really has no particular situation like that to say the counseling and all that. They just want sent to a doctor's office, want to appeal. And it's not that simple. So when we get into a discussion about the behavior, one's become very dangerous in a way, either hurt himself or hurt other people in the environment, either in memory care or in the board and care centers. Usually any psychotic medicine will be discussed and will be used either by the doctors responsible for that care or primary care doctors. Usually for a short term only, for situations if it's possible, but always need somebody guided. The person who dispenses medicine for that situation is very crucial. So they have to make a judgment whether they really need our medicine at that time. Particularly acting out based on delusional thoughts and based on the hallucinations. Those are proper indication to use the medicine, but usually for a short period of time or just 1 night or 2 nights. However, if they have suicidal thoughts, they have behavior like my patient, they jump out of doors and they go out to jump out of bridge, want to commit suicide, then they have to go to psychiatric hospital. There are people actually will pull out the guns and trying to shoot with either shoot themselves or shoot. Those are extremely behavior. Then you have no way to solve. You have to call the police officers and then to go for proper channel for that. So it's really, they are from very mild to a very extreme cases, and then also depends on the environmental situation, either at home with the family members or in a facility, large facility or small facilities. We need to be discussed individually.
Okay, let's switch gears and then we'll come back to some more language and other things. I am a primary caregiver for my wife with FTD. She sometimes threatens me with calling 911 if I do not comply to her request, saying she will tell police that I hit her. I would never do that. How do I protect myself from this type of situation? I'm going to take a stab at it first because I've actually had a case like this. My patient would call the SWAT team in the middle of the night, and the poor wife would wake up with bullhorns. This is a SWAT team, come out with your hands up type of thing. And after this happened 3 or 4 times, Dr. Mendes and I talked to the police department, and we had an investigation that the home was safe. We had Adult Protective Services come in and make sure that the home was safe, that the person with the illness was not being hit or abused in any way. That was a record of note. The police department then assigned one particular team in case that patient called in the middle of the night, and it was routed through that team, and they no longer had to take action. So unless someone has another suggestion, my advice was for the let's see, the husband, I would call Adult Protective Services and ask for an evaluation to have a record that no harm is being done to this person. So you ask so you don't get in trouble from that situation. Anything else?
The only thing I would add, and I totally agree, I would call EMS and 911, and
Explain
so that
EMS.
for all EMS services, but also if your particular area has a dementia-capable programming where businesses in the area and efforts are being made to train, get in contact with them about what services they have. Because I know in North Carolina, even just our city is working on it, and we have specific teams of EMS workers that know about dementia and consequences. So you can be really helpful in setting up some of those initial processes.
Right. And I have a current case the other way, where the husband is the patient, and he was being violent to the caregiving wife. She's much younger than him and has young boys, like 12 and 14. And so we did call the police, and they want her to call them. And she said that was one of the pivotal points about, she dissolved the marriage recently because of how painful it was to have her 14-year-old son call 911 on his father while he was attacking her. And the police wanted to be called so they could help. And so we tell them, call 911 if you're in this situation. But it does help if the 911, if first responders are trained and informed. But just a sad situation.
Okay, another question. In my mom's head, is she thinking coherently, or are her thoughts as confusing as her expressive language? And is there any advice you have for communication with someone with severe aphasia?
How many hours do we have?
Yeah.
Learning the tools for communicating with someone who has aphasia is really important, and there are becoming more and more opportunities for you to find that information both online and at local aphasia centers, or to pair up with your speech therapist. It's really interesting that over this whole day, I've spoke with so many families who said, they had speech therapy, or they're going to go back for speech therapy, but all they did was work on worksheets. Your speech therapist is your communication coach, and everybody's communication is different. So to be able to learn some of the tools and tricks that are specific to the person you care about is so essential, and the speech therapist is trained on how to do that. So find someone who knows aphasia, adult neurogenics, and ask them to be your coach, even if you pay out of pocket for a couple sessions to have that triad where you really learn the techniques. To the point of the aphasia without any additional cognitive impairment on earlier stages of PPA, for example, where somebody is purely impaired from a linguistic standpoint, I am of the belief that they get so much more receptively than we could ever assess expressively. So that it is really important to give dignity and respect to the fact that they probably do know what they're thinking, they just can't access the language to be able to communicate what their thoughts or ideas are.
Next question. How do you persuade clients with FTD ALS, swallowing issues, to use Thicket and to adhere to other choking precautions?
Is it going to go to me again?
No. I'm thinking about it too.
Yeah, I mean, being able to understand why you need to modify a diet and modify liquids, because Thicket does change the consistency and therefore the pleasure of drinking whatever you're drinking. Hiding things in food and stuff is not what we want to get to. We want to be really honest that if you're having challenges with swallowing, that this could result in some serious medical things. I'm a big fan of providing that information with pictographs or with visual cues to show somebody why and what this happened. So get a picture of, or go online and get a video of swallowing and what it looks like to aspirate, and this is why it's dangerous. We're again remembering that comprehension is there, especially if it's the ALS uniform, is that you understand, it's just that you don't want to do it and you don't feel like it's a big deal.
The other thing I wonder too with this question, at least in some of the individuals I've worked with, sometimes there's tension between the person with the illness and the family member. And the family member, the care partner, is often in a situation of having to control and manage so many things, like serving as the frontal lobe for the individual who is impaired. What I have found helpful is to have an outside person, an expert, a speech therapist, one of our ALS specialists, to sit down and really talk to the person. And then it's not always on the care partner, like bringing in someone else. Sometimes that relationship can change, and you're not getting into all the other issues that are going on in the home. Anybody else have anything to say? We did that. Okay. This has come up in a couple other sessions. My husband's doctor is in Connecticut. That doctor said we must have a neurologist to manage his FTD. We are now in Florida, where the doctor says no neurologist needed. Geriatric psychiatrist is all he needs. Who do I believe? Now he has essential tremors. Shouldn't he be treated by a neurologist?
It depends on regional. Actually, it depends on your care. Actually, the so-called dementia specialists depends on the training. They are geriatric physicians. They are also well-trained in dementia. They are geriatric psychiatrists. They are well-trained in dementia. The neurologists, actually, not all neurologists can see them. It's actually the neurologist specialized dementia, they're more comfortable to see them. So it's really depends on regions, special training, either psychiatrists or geriatric physicians or neurologists, they all can approach that. It just if it's just tremor, they're more, certainly neurologists are more qualified, but if it's tremor-related dementia, the psychiatric doctors, they usually can know, but they usually will refer to neurology. They have to,
Yeah. I also think that I think it was suggested in one of this morning sessions, asking the doctor that you're seeing, in this case the geriatric psychiatrist, how many individuals with FTD he or she has seen. How familiar are they? And it depends on the issue, I think. If the issue is a diagnosis, you may want to have the neurologist, but if the issue is a behavior that you're trying to control with medications, geriatric psychiatrists are often have more expertise in doing that. For the essential tremor, it might also be a side effect of one of the medications that are being given for behavior. So there should be one captain of the ship, or Captain S of the ship, who's organizing all the care to make the referrals when the individual needs more, and be a squeaky wheel. Say, okay, you can manage these things, but what about the essential tremor? Can you manage that too?
I would agree that you really need to feel empowered to advocate for the person that you're caring for, and that if you go in all very organized, and I'm a big fan of getting yourself a binder, and I mean a physical binder, and having sections for each of the doctors you see, all of the test results. Have it there, have your questions prepared before you go see somebody, and bring that every time, because then, they can see. And what I include in this recommendation is a fold-out sheet that's a timeline, where they can kind of see what you've tried. Because when you get there, you have your, 10 minutes that you're allowed with the doctor before he has to go into the next room. And you're trying to go, oh, and then this happened, and what should I do about this? Instead, go, and I sometimes would even send it ahead and say, can you take a look at this? These are going to be the questions I asked. And all the physicians that I've ever worked with say they really appreciate the organization and the knowledge that they don't have to kind of go back and forth, but that you've come with the information.
So just a couple more that are along these lines that were just handled. What to do with conflicting medical prescriptions between neurologists and psychiatrists. Number 2, is a geriatric psychiatrist necessary to be part of a professional care team? If so, would a general psychiatrist be just as good? I'll start with this. If we think about a problem-solving approach, if you can identify the problem that you're going to a physician about, is that problem being helped? Is the problem compulsive eating? And is that medical team able to give you the guidance that you need to help that problem get better? Then you're probably with the right team. If you're not being helped, then you need to say, I need more help, and where can I go? Can you refer me to someone? The title isn't what's important. It's the expertise. It's the expertise that the treating team has in caring for behavioral issues related to FTD. Okay. Anybody want to add to that? Okay. At what point does one know when to place someone in a home care environment? After caregiver burnout?
Boy, I wish I had the recipe for that one. I find it's very idiosyncratic, and it's very, person specific. So I have a lot of families, because I'll ask that, right? I don't want it to be a surprise. We kind of talk about it, at many group sessions, or when we see them, what has changed, how's it going? And I'll say, well, they seem to be doing well, and you're coping well as the daughter. So I'll say it, do you feel it's time? How exhausted are you? Are you up all night? I think these are the things I worry about. And many, many caregivers will say, because I'll ask, when do you think it's time? And incontinence, especially when it's the wife is the caregiver, and we have still a very large man, and the thought of dealing with physical care, things like picking him up when he falls, but changing depends, and bathing when they're so large, and if they're combative. So they'll start with that. I guess when we get to that point, I may really need to do something. And it never fails to amaze me. They'll get to that point, and they'll go, it's not as bad as I thought. We're still managing fine. And they can do this for quite a while. And we try, toileting regimens and the whole 9 yards. But they seem to rally, even though they think that will be the litmus test. So I find it's very different. I also find sometimes that primary caregiver is such a martyr, and we often end up with that person ill, and seriously ill, or something's happened, pneumonia, a hospitalization, a fall and a broken hip. And, they may die of a heart attack or cancer before the patient. And then, was there a plan B? Who do we call? We really want to work on those too. But I see this whole continuum of issues that come up. And so when the family starts to see mom, the caregiver, decline, the adult children may come in and say, we need your help. We really think it's time, and she's not seeing it, but they'll lay that out for me. So we work on that. And our behavioral neurologist, I haven't heard that specialty thrown out, but we have a couple behavioral neurologists in the clinic, most of them trained by Bruce Miller out here. All of ours have been trained by Bruce Miller. And boy, they just don't pull back. They don't hold back those punches. They will say, it's really time you have a plan. Like, he should have been placed already. And they'll really make those caregivers think about it.
It's actually individual based on caregivers. Some of them, they already have the plan, they just need support. But some of them, they just need a support for that decision. They just want support for that decision. They already make decisions. Some of them, they already had the person already hired in the house. Some, if they're financially actually sound, some people actually hired 3 shifts at home to provide the care for them. And then that's like turning into the nursing home in their own home. So really depends financially what they can afford it, and they have different ideas. They just want to know what is the best. My statement usually, there's no which one is best. The one you feel most comfortable with, the more practical you can afford, that is the best for your situations. But there's no universally which is the best.
I think we also have to remember that, and this was a really interesting study I saw about how individuals who love someone with aphasia, whether or who have FTD, are not generally considering themselves as caregivers. They consider themselves a spouse. They consider themselves a daughter. They don't access the resources for caregivers. And I think as a community, especially this community of AFTD, we have to look at maybe changing the verbiage we use so that people realize, oh, they're talking to me? I didn't realize you were talking to me. I'm just doing my duty as a daughter. I'm doing my job. I'm in the healthcare field, and I didn't access resources for caregivers because I didn't identify myself as a caregiver. So then when caregiver burnout happens, you're like, oh, that was me. Mm-hmm. So I think that's one of the avenues we have to reach more people.
So I think I have time for 2 more questions, and I'm going to try to do these quickly so we can have time for another one that I think that we haven't addressed yet. One question is, do you leave local doctor for the medical research center? Let me start with that. We talked a lot about research and the value of research, and I coordinated all of our research studies for FTD at UCLA when I worked there, and we never advised our patients and families to leave their local doctor. We made sure that all their physicians had reports of everything that we did. We tried to work in conjunction with them. However, I would discuss it with your research team. Can they handle everything? Often research teams are not addressed to handle a call at 3 p.m. saying, I need some help now. So ask your research team, but we wanted our families connected to local doctors. And when you mention medications, can you please name some of the common ones used by FTD patients? So I'm going to refer you to the Partners in Care on the AFTD website. Search in their search box under Partners of Care. We've just come out, I think our latest edition was medications. And we had a guest geriatric psychiatrist who wrote that. And all of the medications are listed there in more detail than we can give you right here. So I think that's a better use of your understanding. And then I can't find the card right at the moment, but the last question, someone wrote that she has, her husband has FTD, she has teenage kids at home, and their friends are adult kids, and the friends are saying, I know how you feel, my grandmother had Alzheimer's disease. And it makes the adult children or the teenagers feel horrible from the card, that they have no one who understands, and it makes them angry. And the children are worried that there's a time that they will no longer remember the relationship that they once had with their father. So does someone have an idea? There is a group for teenagers and young adult caregiver, care partner support group through the AFTD.
Right, and I invite them. We've had the children, some young ones, the 12 and 14-year-olds. They came to our food for thought activity. So we make it more social, and at that one we invite the patients and the care partners and the families and whoever you want to come in. We do that a couple times a year in a more social environment. We don't have enough people to run a separate group for children, but we do try to include them, and we certainly support the younger mothers that have still teenage kids at home and talk about these things. But it is difficult for them. And teenagerhood is awful. I have 5 kids. Their adolescence was terrible at the best of times, and we were okay. So to watch your father deteriorate, and when they have aphasia or a PPA and can't speak to their kids, it really damages the relationship, and the kids don't have the skills to communicate and develop a different relationship with dad, and so we try to help with that.
Yes, and the AFTD does have some specific pamphlets for teenagers, and at one point I think they had a telephone support group.
Yeah.
So I think we're out of time. These were wonderful questions, especially at the end of the day. I hope you've enjoyed this conference as much as I have. I've been to many of them, and this is one of the best ones I've ever seen. So thank you for your participation, and enjoy the reception. We can talk more.